Hello everyone and welcome to our module on other cancer drugs. Many of the cancer drugs we'll discuss in this video are monoclonal antibodies, so let's talk about what a monoclonal antibody is. Monoclonal antibodies are laboratory-produced antibodies derived from cloned cells in culture, and they're designed to bind to a specific antigen, usually a surface protein on a cancer cell. And when they bind to the cancer cell, they either block a receptor on the cancer cell or they lead to immune system killing of the cancer cell. And this is nice because these represent targeted therapy of cancer cells, and these drugs usually have much less side effects compared with traditional chemotherapy. Monoclonal antibodies are administered by intravenous infusion. Most patients will go to an infusion center on a regular basis to receive an infusion of one of these drugs. Many of the monoclonal antibodies can lead to what's known as infusion reactions. These usually occur after the first or second infusion. As the antibodies bind antigens, this leads to cytokine release, and that leads to symptoms. Most of the symptoms of infusion reactions are mild to moderate. They can include things like fever and chills, flushing and itching, or skin rashes. Sometimes they include GI symptoms like nausea, vomiting, or diarrhea. And in certain cases, especially with some of the antibodies that are known to cause more severe infusion reactions, treatment or prevention can be done with antihistamine drugs or steroids. The first drug we'll discuss is bevacizumab, which usually goes by its trade name Avastin. Bevacizumab is a monoclonal antibody to VEGF-A, and I'll talk about what VEGF-A is in a minute, but the antibody prevents VEGF-A from binding to the VEGF receptors, and this is used in many solid tumors, including colorectal cancer, breast cancer, and renal cell carcinoma. So let's talk about VEGF in a little more detail. VEGF stands for vascular endothelial growth factor. This is a family of signal proteins. There are several forms: VEGF-A, B, C, and D. VEGF-A is important for stimulating angiogenesis, and it is secreted by many tumors, and this leads to vascular growth so that the tumor will have a blood supply. Therefore, if you can block this system, you can cut off the vascular growth of the tumor. And VEGF inhibitors are used in a couple of scenarios. Bevacizumab is used in cancer. That's what we're talking about right now. In addition, there is another VEGF inhibitor called ranibizumab, which is used in retinopathy. It's injected into the eye to prevent growth of blood vessels in the retina. To understand the toxicity of bevacizumab, you need to appreciate that the VEGF system mediates vasodilation via nitric oxide. Therefore, if you inhibit the VEGF system, you get vasoconstriction. For this reason, cardiovascular adverse effects are common among patients receiving bevacizumab. These patients can develop hypertension. Also, clinical trials have shown an increased risk of arterial thromboembolism in patients receiving VEGF inhibitors. This includes myocardial infarction and stroke and TIA. There are also other adverse effects related to other actions of VEGF. VEGF is important for wound healing, so patients receiving these drugs display delayed wound healing. In addition, there is more bleeding among patients receiving these drugs because VEGF is important for maintaining the health of blood vessels. Next, we're going to talk about drugs that interfere with the EGF system. So let's talk about that system in general first. So EGF stands for epidermal growth factor. It is a molecule that stimulates cell growth and differentiation. It does this by binding to the EGFR, the epidermal growth factor receptor. This is a tyrosine kinase receptor, and what that means is that the receptor contains tyrosine amino acids, which will become phosphorylated when the receptor is activated. Thus, the EGF-EGFR binding leads to phosphorylation of tyrosine residues in the receptor, and the phosphorylated EGFR leads to downstream effects that lead to cell growth and differentiation. And it turns out that the EGFR is overexpressed in many tumors, and therefore it is a target for therapy. And here's a picture just to help this stick in your mind. So EGF molecules will bind to the EGFR. That will lead to phosphorylation of tyrosine amino acid residues on the EGFR, and that will lead to the downstream effects of the receptor. Cetuximab is a monoclonal antibody that binds to the extracellular domain of the EGFR, and in doing so, it blocks the binding of EGF to EGFR and prevents activation of the EGF system. This can be used in some solid tumors, including non-small cell lung cancer, colon cancer, and also head and neck cancer. The side effects that have been seen in clinical trials include an acne rash on the face. I'll talk more about this in a minute, but this is a common side effect to drugs that interfere with the EGF system, and also diarrhea. Some tumors, even though they express the EGFR, do not respond to cetuximab, and this is because they have something called the KRAS mutation. This is seen in some cases of colorectal cancer. KRAS is a G protein that is downstream of the EGFR, and it can acquire activating mutations in some cases of colon cancer. These mutations isolate the tumor cells from the effect of EGFR, and thus even if you block the EGFR receptor and the EGF system, it will not limit the growth of these cells because they have activating mutations of KRAS. So an important clinical study was done in 2008, the reference is at the bottom of the screen here, and what it showed is that tumor cells with a mutated KRAS had no benefit from cetuximab. In other words, the tumor showed no response to the drug. On the other hand, tumor cells that expressed the wild type or normal KRAS did respond to cetuximab, and there was a benefit. And just to make this very clear, if we go back to this slide here, what happens with a KRAS mutation is that downstream of the EGFR, there is constant activation leading to cell growth. Thus, even if you block the EGFR with cetuximab, there's no benefit. In other words, the tumor cells don't stop growing because there's an activation downstream of the receptor. Erlotinib, which also goes by its trade name Tarceva, is an EGFR tyrosine kinase inhibitor. It is an oral drug. It is not an antibody. This is its structure shown on the screen here, and its goal is to inhibit the tyrosine kinase enzyme activity of the EGFR. But it has a similar effect to cetuximab in that it disrupts the EGFR system, and therefore it has benefit in some malignancies. And its major use is in the treatment of non-small cell lung cancer. The main adverse effect of erlotinib is a skin rash. This is an acne-like eruption that occurs on the upper torso, face, and neck. And there are some data that suggest this may actually be an indicator of the drug effect. Patients who have significant acne often get more benefit from the drug. And this adverse effect is seen with all EGFR blocking drugs. We talked about this before, how patients on cetuximab can also get an acne-like eruption. The same thing happens in patients taking erlotinib. So erlotinib inhibits the tyrosine kinase activity of the EGFR system, but there are other drugs that inhibit the tyrosine kinase activity in other cell signaling pathways. It turns out that many cell signaling pathways depend on tyrosine kinase activity, so there are a number of different tyrosine kinase inhibitors that are useful in different malignancies. One of those inhibitors is imatinib. Imatinib is also not an antibody. This is its structure here. It is a tyrosine kinase inhibitor, and its major role is in chronic myeloid leukemia. I talk about this in detail in the hematology section in the videos on leukemia, but by way of brief review, in CML, the Philadelphia chromosome leads to fusion of a BCRL-ABL fusion gene. This gene produces a tyrosine kinase protein, so you can treat CML with the tyrosine kinase inhibitor imatinib, which will inhibit this tyrosine kinase protein. And there are other tyrosine kinase inhibitors that are also used in CML. Those include dasatinib, nilotinib, and also bosutinib. Imatinib also has activity against gastrointestinal stromal tumors. These are very rare tumors of the stomach and small intestine. They are associated with c-KIT mutations, which I'll talk about in a minute, and they can be treated with surgery plus or minus treatment with imatinib. KIT gene mutations affect the KIT protein. It's also called the c-KIT protein. It is found on the surface of cells. It's also called CD117, and the KIT protein is a tyrosine kinase receptor. So it's a receptor that binds a ligand and has tyrosine kinase activity. Specifically, it binds the KIT ligand, which is also called stem cell factor, and this stimulates the growth of cells. So KIT gene mutations can lead to cancer. The KIT gene is a proto-oncogene. It's a gene that has normal function but also can become an oncogene. And KIT gain of function mutations are found in 95% of GI stromal tumors. Most of these cells are CD117 positive, and they have a gain of function mutation of the KIT gene. And therefore, you can treat GIST tumors with inhibition of the tyrosine kinase activity of this receptor using imatinib. Some of the adverse effects of imatinib are shown in this slide. It can lead to fluid retention. This is usually peripheral edema, as shown in this picture on the right side of the screen, or sometimes it is periorbital edema, as shown in this picture here. Rarely it can cause pulmonary edema and shortness of breath. And then imatinib is also associated with a skin rash. Our next drug is rituximab, which is a monoclonal CD20 antibody. It binds to the CD20 surface marker on B cells and leads to the depletion of B cells. And this is beneficial in B cell malignancies and also in some autoimmune diseases where B cell proliferation leads to overproduction of antibodies. Some of the B cell malignancies where rituximab has been used include non-Hodgkin lymphoma and also CLL. The autoimmune disorders where rituximab is sometimes used include rheumatoid arthritis and also ITP. I talk about ITP in the platelet disorders video. In this condition, antibodies are produced against platelets that lead to platelet destruction. The first line therapy is IVIG and steroids, and the second line therapy is to remove the spleen. However, an alternative to splenectomy is rituximab. In some patients, this will lead to an improvement in the platelet count. The toxicity of rituximab has to do with the fact that rare cases of opportunistic infections have been reported among patients receiving this drug. Because it depletes B cells and dials down the immune system, opportunistic infections can occur. Some of the infections that have been reported include pneumocystis jirovecii pneumonia, cryptococcal meningitis, CMV colitis, and importantly, progressive multifocal leukoencephalopathy, or PML. This is caused by reactivation of the JC virus, and a couple of fatal cases have been reported in patients on rituximab. So any patient receiving rituximab who develops a new neurological symptom needs a workup for PML. And then finally, hepatitis B reactivation has also been reported to occur in patients on rituximab. Our next drug is tamoxifen. This is its structure shown at the top right of the screen here. Tamoxifen is a selective estrogen receptor modulator, or a SERM. It is an oral drug that's used in the treatment of breast cancer. It's useful in breast cancer because it's a competitive antagonist of the estrogen receptor found in breast cells. It's used in breast cancers where the tumor expresses the estrogen receptor. These are called ER-positive breast cancers. It can be used as part of primary therapy for the tumor, together with surgery and radiation and other chemo. It's also used for prevention in women who have recovered from breast cancer. In order to understand the effects of tamoxifen on the body, you need to appreciate that although it blocks the estrogen effects in breast cancer cells, it works as an estrogen agonist in other tissues, especially in the bone and the uterus. Recall that in the bone, estrogen promotes increases in bone density, and in the uterus, estrogen promotes endothelial growth. So both of these effects can be seen in women taking tamoxifen because of the estrogen agonist effects of the drug. The toxicity of tamoxifen includes hot flashes. You are blocking the effects of estrogen, so this is like causing menopause, and therefore menopausal symptoms can be seen. In addition, there is an increased risk of DVT or PE. This is because estrogen leads to an increase in clotting factors, so the estrogen agonizing effects of tamoxifen can cause this to happen. This is also seen in women taking birth control pills for the same reason. Because tamoxifen is a partial agonist to the endometrium, it can stimulate endometrial growth. So women on this drug can see endometrial proliferation and hyperplasia and polyp formation, and it may lead to endometrial cancer. Its use has been associated with invasive carcinoma and uterine sarcoma, and the major risk is in postmenopausal women who aren't having regular menstrual cycles where they shed the lining of the uterus. Let me mention the drug raloxifene, which is also called Evista. It is also a SERM. However, it is rarely used for breast cancer. It is more often used for osteoporosis. That's because it has estrogen actions on bone. It is anti-estrogen in the breast and uterus. So it's often used in osteoporosis in postmenopausal women because it will promote a rise in bone density. It's also sometimes used for prevention of breast cancer, but not for primary treatment. Just like tamoxifen, it may cause hot flashes, and just like tamoxifen, it's associated with DVT and PE. So tamoxifen blocks the estrogen receptor, and in doing so, it blocks the effect of estrogen on breast cancer cells. Aromatase inhibitors inhibit the enzyme aromatase, which leads to the production of estrogen, but the goal is the same as for tamoxifen. It's to block the stimulation of breast cancer cells by estrogen. So aromatase inhibitors are used in estrogen receptor positive breast cancers, just like tamoxifen. These drugs are only used in postmenopausal women. Premenopausal women have too much estrogen production coming from the ovaries, and these drugs are not effective. There are 3 drugs in this class: anastrozole, letrozole, and exemestane. Their structures are shown at the bottom of the screen. Exemestane is different from the others in that it has a steroid chemical structure, but all 3 of these drugs block the production of estrogen. It's produced in peripheral tissues, but it turns out it's also produced in significant amounts by breast cancer cells themselves, and therefore inhibiting the production inhibits the stimulation of breast cancers. These drugs all inhibit the enzyme aromatase, which leads to the production of estrogens. Aromatase converts androstenedione into estrone and testosterone into estradiol, and these are both estrogens, and therefore when you decrease their production, you decrease the amount of estrogens in the body and the stimulation of estrogen receptor positive breast cancer cells. One of the major adverse effects of these drugs is osteoporosis. By decreasing the amount of estrogen in the body, there will be a loss of bone density, and therefore there is an increased risk of bone fracture among women taking these drugs for breast cancer. Our next drug is trastuzumab, which most people call by its trade name Herceptin. Trastuzumab is a monoclonal antibody to HER2. HER2 is a surface receptor, and its activation leads to cell growth and proliferation. It's overexpressed by many cancer cells, and it's expressed in 25 to 30% of breast cancers. So this drug is often used in breast cancer. And one thing that's confusing about HER2 is that there are many names for this surface receptor. It's also called HER2/neu. It's sometimes called ERB2, and it's also called CD340. HER stands for human epithelial receptor, and there is a family of HER receptors that all have an inner tyrosine kinase domain, just like many of the other surface receptors we've talked about, and activating these receptors leads to a signaling cascade which leads to growth. And the HER1 receptor we've actually already discussed. The HER1 receptor is another name for the EGFR that we talked about earlier in this video. We're talking about the HER2 receptor now, which is found on many breast cancer cells, and there is also a HER3 and a HER4. So trastuzumab binds to the HER2 receptor and leads to improved survival in breast cancer patients. It's been shown to inhibit proliferation of tumor cells, and then importantly, it's also been shown to lead to antibody-dependent cell-mediated cytotoxicity. This is an important tie-in with immunology that's high yield for step 1. In the immunology section, I talk in detail about antibody-dependent cell-mediated cytotoxicity, but by way of review, this is a mechanism of killing cells by the immune system that does not involve phagocytosis. In antibody-dependent cell-mediated cytotoxicity, a cell is tagged by antibodies as shown in this left side of this picture here. An effector cell then binds to the Fc portion of those antibodies and releases toxic contents that kill the cell. The effector cells are often natural killer cells, but sometimes they are other cells of the immune system. So the important thing for you to know is that there's fairly good evidence that the way trastuzumab works is by triggering this immune system process, and this is basically targeted killing of cancer cells by the immune system as a result of this antibody drug. Trastuzumab is associated with cardiac toxicity. It can lead to a cardiomyopathy. This is usually an asymptomatic fall in the left ventricular ejection fraction that is detected on routine imaging. However, in some cases it can lead to heart failure symptoms like dyspnea, fatigue, and edema. This most likely happens because of blockade of HER2 in myocytes, which can lead to stunning of the myocardium. And importantly, this is a much less severe form of cardiotoxicity than is seen with anthracycline chemotherapy. In the video on anti-tumor antibiotics, I talk in detail about anthracyclines and how they can lead to a serious cardiac toxicity, including permanent heart failure. Trastuzumab cardiac toxicity is different. It's not dose dependent, and it's often reversible when the drug is discontinued. In fact, you can even sometimes re-challenge patients who have had recovery of their left ventricular ejection fraction and administer trastuzumab again, and it is well tolerated. And if you do a biopsy of the heart in patients with cardiomyopathy on trastuzumab, you do not see necrosis. That is also different from anthracycline cardiotoxicity. In anthracycline patients who develop cardiotoxicity, there's necrosis of the myocardium, and therefore that is often a permanent complication of treatment. Trastuzumab cardiotoxicity often resolves. And that concludes our video on other cancer drugs.